Greetings. Good day, good morning, whatever time it is, wherever you are. This is Andy Revkin. I direct the nascent Initiative on Communication, Innovation, and Sustainability at Columbia University. And a month or so ago, I launched this new project called Sustain What, which is a running conversation aimed at clarifying pathways both to limit the losses now from this pandemic and to build a more resilient community, science enterprise, to integrate knowledge with action more than we have in the past. On my blog a long time ago, I posted a reader comment. The expression was, "Are we stuck with blah, 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 bang?" And I would like to think we're not stuck with blah, 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 bang. But it's going to take a lot of work, both to respond currently to what's happening in the world and to build a better world going forward. So Jeff Schlegelmilch, who's the Deputy Director of the National Center for Disaster Preparedness at Columbia University and the Earth Institute, is with me right now. I'm bringing in Rolf Halden. Hello, Rolf. Who's at Arizona State University. And,
hi, thanks for having me.
Rolf he's a professor and director of the Biodesign Center for Environmental Health Engineering at ASU. And the thing that really got my attention was the concept that they're building there of a human health observatory. I have been thinking a lot in recent years about the microbiome. You've heard about that there are more bacterial cells in our bodies than there are human cells. We are multitudes, as Ed Young wrote in a great book. But there's a macrobiome that we live in too, and that's how this virus that emerged crossed a species line somewhere in China 4 or 5 months ago and has gotten around the world so fast that a week and a half ago it killed the first Yanomami Indians in the Amazon, deep in the rainforest. So that's the macrobiome. We are all connected, just like we are by climate as well. Great to have you, Rolf. It's been a while since I've been down to ASU, which, like Columbia, has a great tradition of focusing on these grand challenges of sustainability. And Angela Rasmussen is here as well. Angela, good to have you back on, as with Jeff, on Sustain What, this project. And I wanted to just start by, Angela is a virologist at the Mailman School of Public Health at Columbia. And we were discussing just last week with Howard Frumkin and others, pathways to progress at the community scale. How can we fast track getting enough awareness of what's going on with this virus in various places, so you can think about moving from the hammer lockdown to the dance, which is this kind of monitor and respond and isolate and track and keep moving. So the first thing I would love to do is just to get each of you to summarize how you're doing and where you are in the world and what's on your mind. Maybe we'd start with Rolf, who's new to this program. So Rolf, how are things? Are you in Tucson or Phoenix, and how are things going?
Yeah, so I'm in the Valley of Sun. That's Phoenix and various cities, including the city of Tempe. And we are not an epicenter yet. You might have seen the paper. We are modeling, what the situation could look like, and we are actively monitoring the city of Tempe, our wastewater here. And so for us, it's a curious time because we've been, thinking about this scenario of building a human health laboratory and having an early warning system for many, many years. And people used to laugh at us, and we got lots of actions of grant proposals to show, and we built it anyway. And lo and behold, now we're in a very good position to leverage this and to go back and look how the situation was in the past, as well as have everything in place to not only acquire samples and analyze them, but also display those that information in essentially real time to all the stakeholders, including the public. It took a long time to work up, and we established this with an opioid dashboard you're displaying right now. So we, for the past 2 years, have shown everyone in the city of Tempe how much heroin and fentanyl and other licit and illicit drugs are flowing below our feet in the sewers on a neighborhood level. So, and we are not just essentially grabbing this public health resource that we've built over the past couple of years, and we'll add the COVID-19 virus to the mix, and hopefully can save more lives and essentially battle 2 epidemics at the same time, right? The opioid epidemic as well as the SARS-CoV-2.
And I think I'd seen that you were actually working on tracking flu virus before coronavirus 19 hit. So this idea of getting a viral infection trends was already something you were working on?
That's correct. And so we not only did we collect wastewater, and so we have those samples archived, but we also proposed to the National Institute of Health an early warning system for the seasonal flu, which we know claims many thousands, tens of thousands of lives, depending on a good or bad year, every year in the United States. And so we proposed to have an early warning system and measure flu wastewater analysis. And in order to understand whether the data is good or bad, we said we have to embed a clinical study. And so we also collected swabs that were collected at a health clinic from individuals presenting there with flu-like symptoms. And we saved all those samples. And then the COVID-19 epidemic kicked in, and we realized that we now have, not only the wastewater archive, but also the clinical samples. And my colleagues, Matthew Scotch, a bioinformatician, and Arvind Varsani, a virologist, they already have went to town on these samples, and we isolated new sequences, and they are submitted for publication. So there's already, information flowing out of those samples collected for the seasonal flu.
That's pretty remarkable. And I guess it's hard for us to understand sometimes that we are an ecosystem as well as a human system, that we have all these the things that come in and the things that go out from our lives, from our individual homes, are all connected in ways, and that essentially a wastewater system is an aggregator. It's a way to look at the overall flow of that at the neighborhood scale. As soon as, at least if you have a mapped system, right, you can then map those flows. Is that how it works?
Exactly. Yes. So we essentially, we are all connected. And the wastewater is essentially a sample that represents almost the individual sample of a city. So as you go and see a doctor, you give a urine and stool, and you get your personal diagnostic. And we as engineers, we just go to the city and take a sample that represents the entire city for a 24-hour period. And it's amazing all the things we see. We just yesterday had a press release with 3 new papers coming out, one showing that we can measure nicotine, alcohol, caffeine, so we can measure the health status and the behavior of people. And then another one that showed how far we can look down the pipe as a function of temperature. As the climate changes, our visibility in the sewer, so to speak, is changing. And during the hot seasons, we have a shorter vision, and in the colder periods of time, we can look further out into our community. And then a third paper that actually goes into COVID-19 modeling and shows the signal that we can measure and what it can and cannot display in terms of what's really happening in the sewer shed. And that's all dependent on temperature regimes and different situations, and what we call the as-built, so this grid work of pipes that runs underneath our feet in the cities, how that is constructed. And so we ran through a modeling exercise to understand what the signal might mean, and how many different scenarios can lead to the same read-off at the monitoring location.
That's so interesting. So Jeff, I think Jeff has a very broad portfolio now at the National Center for Disaster Preparedness, but I think you have a background in epidemiology, if I'm not incorrect. Is that right?
Yeah, I'd be rough. I worked as an epidemiologist. I wouldn't go as far as to say I have a background in epidemiology. So but I do have a background. I started my career in the Boston Public Health Commission, where I served as a public health preparedness planner, as well as in the role of an epidemiologist for a while. I always qualify that because I'm not trained in epidemiology. I have my master's in public health, but not specialized in epidemiology. So I did a lot of great work actually working with not wastewater in particular, but looking at proxy measures of disease burden to look for clues. This was in the early years post 9/11. The big concern was bioterrorism. So looking for signals that you might not otherwise get, which turned out to be not as real time as an astute physician reporting that they're seeing something weird, but then we found out that it actually added incredible richness to our understanding of the disease burden in the city and the baseline disease burden in the city. And when other events were happening, other infectious disease outbreaks, it gave us new clues into what that meant. So we had, I worked on the syndromic surveillance system that they had in the city. And so syndromic surveillance is a way of looking at pre-diagnosis information. When you go to the hospital, yeah, you say, you have your chief complaint. My head's killing me, and then the triage nurse enters in headache, something like that. So that data is much messier, but it's much more real time. So that would be an example where, we were one outbreak I was working on was a citywide norovirus outbreak, a gastrointestinal illness. And so we were able to compare that to complaints of dehydration in years past and see a correlation in that year, which was particularly bad, which we didn't see in years past. So it's interesting to hear all of this and hear about how, in public health, we work in these very dynamic, interconnected ecosystems. And so what are the ways that we can take advantage of that interconnectedness to find new ways of looking at problems and potentially new information sources to help fill in some of the gaps, or at least provide a richer perspective of what's going on.
Yeah. There was this moment in the late 90s when I was writing for the Metro section of the New York Times. I interviewed a New York City Health Department public health official who said at that time they were doing a really analog version of this, where they would do surveys of sales, the receipts of drugstores of gastrointestinal medicine, the stuff you take when you have the runs. And it was a way to zoom in on waterborne disease outbreaks. In that case, often the Orthodox Jewish community in Brooklyn and Queens, they would make their own gefilte fish or there would be a spore. What do you call it? Oh God, I'm forgetting the organism. Not leptospirosis. There's another one that would be
Cryptosporidium.
Cryptosporidium, right? Exactly, right. They were finding outbreaks of it through sales of medicine.
Yeah, and actually, so the wastewater analytics again come in there because if you look at sales data, oftentimes people buy medication. If you have a kid at home that has asthma, you always have your EpiPen and your things around. And allergy pills and so forth. But what we see now in the wastewater, we can actually track when people use that medication. And if you sit on a stock of 250 ibuprofen pills, and then you start popping them because you feel like, I got a fever, and maybe that's the onset of COVID-19. We can measure all these, the self-medication on a day-by-day basis. And so it's quite powerful, and it's hard to get. Sometimes you have to pay for all this information on, sales and so forth. There's all the middlemen that, custodians of the data. But we have direct access to this now through the wastewater. It's really exciting.
Yeah.
Interesting footnote to the drugstore, the sales surveillance, as it uncovered some meth labs in a couple of cities too. So did sales of Sudafed and some other precursors to methamphetamines. So,
yeah, Angela, I wanted to bring you in here now too. Both first to just check on what's on your mind right now these days, and you're tracking the virological questions. There's in all these arenas, there's two questions. There's what do we do now to limit the losses now as this unfolds still across the world and across the country. And then what are the lessons here for how to have a more preventive, more responsive, more intelligence-consuming way of reducing risk in the future? So, what's your top list right now these days?
Yeah, so I'm thinking about a lot of things because this past week has been, there's been a lot of COVID news. I guess there is every week, but this week in particular, we've seen the sort of wide scale rollout of some of these serology tests, as well as a couple large reports anyways of big serology surveys. So there was the Santa Clara County study, which has some problems with the way that it was conducted. There's also the report that in LA County, we haven't actually seen the data for that, but they reported that they have also done a large sero survey to sort of begin estimating prevalence in the community. But I'm really glad to be on here talking about this today, because I think that even though we have all of these new tests and this new testing capacity, there are still problems with the serology tests. Specifically, there's a big problem with some of the tests producing false positive results, which if the overall prevalence is low, which it does look like it probably is, depending on the community, then you could have some really wide ranges in estimated prevalence, the number of people who might be immune. So we really need other methods, creative methods of tracking this. And this sewage idea is a great idea. I mean, they've been monitoring polio like this for a long time. And polio is a very good virus to look at in sewage systems because it's oral fecal. Poliovirus itself is also incredibly stable. So it can last in those sewage systems for a long period of time and may even be a reservoir by which people who are not vaccinated could get exposed. But something it's really great to know that we can also track coronavirus this way. I wouldn't expect coronavirus to last for a long time the way polio does in sewage systems and potentially be an environmental hazard. But this is a really great way to track coronavirus in communities that doesn't require sampling a whole bunch of people. So I think this is exactly the type of sort of creative, innovative approach we need to sort of address some of these issues that we've had in terms of testing capacity at population scale.
So that, which leads back to Rolf, could you describe, I think I've seen in Israel this is happening, in the Netherlands, Massachusetts. What's your sense of the land? Maybe Australia I saw too. There's maybe a dozen or so. Is this still at like the pilot scale test stage, or is this something that can be rolled out?
You know, I think, Andy, we're in a bizarre situation. Imagine if you need a moving truck and one's standing in the parking lot and everyone is driving around with a sports car, you know, delivering parcels. I don't know why it is. What the threshold, the resistance of the funding agencies, of the, you know, people who, you know, assign grants. Why aren't they looking at a tool that now, for the least amount of money, give us the fastest information on the largest possible population? We published a paper that was released yesterday that say that within a couple of weeks, we could measure 2.1 billion people that are connected to 105,000 wastewater treatment plants around the world.
Wow.
And that would cost very little money. Why aren't we doing this? And we're developing, you know, serological tests to look at whether somebody has been exposed. How is that actionable compared to knowing where the cluster is and how we can protect people? So I want to be upfront with you. This technology is not, you know, the silver bullet. But it's an important piece of the different tools that we have in our tool set to manage pandemics, and not only to do it reactively by counting the dead and the sick, but by doing it, you know, proactively, by seeing where a cluster develops and then managing that before it can blossom into, you know, the large outbreaks that we've seen in New York and in the Seattle area and so forth. So who's doing this? Well, there's been people doing this for a long time because it just makes sense. It makes good sense. It's cheap. It's not appealing. It doesn't smell good, but it gives you good results. And it's interesting how, you know, how people are averse to this technology. But nobody has a problem going to the doctor and delivering some urine and stool, right? We all do that. But when you say that you measure, you know, composited wastewater, it's like, oh no, I don't want to fund it. I don't want to know about it. The truth is, that's where the information is. So what can we do with this method? So first of all, I didn't come up with it, right? So this was European researchers that have done this, started this field of wastewater-based epidemiology in the early 2000s. But even before then, we were already looking at infectious disease agents in wastewater. So nobody really invented it, but we have certainly grown and cultivated it. And when we began, we just measured the concentration and reported it and felt good and said, yeah, good job. But then later on, we realized, hey, you got to understand how many people are there. Then the stormwater mixes with the sewage. So there's a lot of math going on until you get it right. And then when you measure a quantity of chemicals in the sewage treatment plant, that chemistry is real. So it doesn't, we always say the sewage doesn't lie. What we measure is the real chemistry, the real biology passing through our monitoring point. But it doesn't necessarily reflect how much was deposited upstream. If the virus degrades, if a chemical like heroin degrades, you know, in the sewer pipe. So, and then as we get exposed, not everything that we take in is being excreted. So there's a lot of calculations, and they have gotten better over the years. And so we have supreme groups now around the world doing this. And so I first want to give a shout out to the folks in Europe, right? So they have built what's known as the SCORE network. And they have monitored in major European cities for many years now, major drugs. And so they, you know, up to 60 cities are included. They have cross-validated their laboratories. They have very good, you know, QA, QC, so quality assurance, quality control, excellent, robust data. And they give us information on how different cities in Europe differ by drug consumption. And then one of those researchers, Kevin Thomas, he moved over to Australia and is now running with Jochen Miller, another professor there, a large network that actually reaches across the whole continent. So Australia is doing this, and they put out an annual report on drug consumption that is federally funded. So they really put, you know, the money where it belongs. Then there's other, China has recently hosted the premier conference on wastewater-based epidemiology. What exactly they are measuring and to what extent is unknown to me. Clearly, it's a wonderful tool that can be used for public health protection, but as well as somewhat for surveillance of activities in a community. And so there's people leading the ethical and moral implications of that, doing research. So it's a field that has seen quite a bit of intellectual contributions from many people around the world. In America, I was always surprised at how little traction we got, and so my group took it on itself to collect samples across the United States, and so we built the largest network in the US, and also have 350 cities around the world, which capture about 250 million people. So 250 million people are captured in the chemistry that we have in our refrigerators and freezers. But why we wouldn't invest more in doing this right now and then getting information on the hotspots? I compare this to, like, if you want to chase a fire, yes, you can go in a car and drive every street and see whether a house is on fire, or you can get in a plane and take a broad view of where there's fire and smoke, and then you send your resources to where these problem areas are. Wastewater-based epidemiology will not help you in identify the individuals, but it will tell you where they are in general, right? So then the emergency responders can come in, and it's a 1-2 punch of identifying an area that needs help, and then sending in the emergency responders. And if you look across the country, we don't have enough tests. So why wouldn't you apply them strategically where they are needed, right? And we are not doing this. And so that is really, I've been pulling my hair out for a long time about this. But now finally, if this is not the day where wastewater-based epidemiology is finally, coming to the front, I know what it takes.
Can I get Angela and Jeff, can you react to this? One thing I wonder about is whether this is a function of the lack of disciplinary crosstalk also. Even at Columbia, the public health school might not be talking to the engineering school about, so within the bigger picture, is that an impediment or just react? It would be interesting to hear from both of you.
I mean, I'm surprised to hear that people have been so unreceptive about it here in the States, although, I mean, on the other hand, I'm not. It's not surprising that it takes a while to get traction with, especially with funding agencies, to try something, even if it's proven to be effective someplace else. A lot of times there just needs to be really a critical mass of people who've decided that this is now a good idea and let's pursue it. It is disappointing, though. I mean, it certainly is a hindrance to innovation. And I agree completely with Rolf that this is a really cost-effective way of monitoring populations at a large scale that doesn't require all of the, interpersonal interactions that, and it is not beholden to a lot of the supply chain issues that collecting samples from individual people is. So I agree that it's not a silver bullet, but it's definitely something that would be really helpful to have in our toolkit in terms of being able to rapidly identify communities that may be having a resurgence or a primary surgence, I guess, of COVID cases, but without having to rely exclusively on either nasal swabs or serology testing. I think that, we should have this more widely, especially now as we start to reopen things. And we need to be able to identify communities that are experiencing a larger number of cases rapidly so that we can go in and do that type of classic epidemiology where we're testing and contact tracing and isolating people who are infected. So I completely agree with everything Rolf said. I think that this should be part of our efforts as we move forward and try to figure out how to reopen society and get back to work.
And Jeff, it's also not only in this case would it help, it seems, with identifying potential hotspots or resurgence, but also as a preventive strategy or like an early warning system. I was so struck by the New York Times story today that looked back at using modeling and other methods to look back at the hidden outbreaks, the early, what was already spreading in the human system before it was spreading symptomatically. And, again, the symptoms, as you said earlier, and as Kirk Smith at Berkeley told me once, doctors are the failure people. When you're at the doctor with the headache or the fever, that's too late, especially in a case like this. So is there a value here in terms of, well, just, again, if you could react generally to how this might be useful and in honest context too.
Yeah, certainly. And I mean, epidemiology, especially this kind of infectious disease epidemiology, is bathed in uncertainty, right? It's you're dealing in chaotic systems. They're not deterministic. There are multiple variables that are feeding into each other that behave independently but impact each other. I think it's partially why, too, in infectious disease epidemiology attracts so many economists, because they have a lot of vocabulary and tools for doing projections and uncertainty. But all this is a way to say, there's obviously a lot of value with this kind of wastewater surveillance, because what it does is it down selects the area that you have to look at in terms of uncertainty, right? It gives you an opportunity to find these hotspots and then deploy more precise instruments in areas where you're more likely. And this is actually methodologically is part of diagnostic testing, right? Doing screening tests and then further testing and things like that, so that you have a population that you're testing that is, it increases the sensitivity and the specificity of the testing. But in response to your question on why this potentially is not being deployed and not being implemented, Andy, I think you said it perfectly, is that it's a very compartmented world out there. Your public health agencies are generally not the ones that are overseeing the mechanics of waste treatment. And so unless you have a novel partnership and those relationships in place, they're not even at the table together for these kinds of things. A colleague in Spain, Lorenzo Cellari, I'll try and find the graphic actually to share, but did this great map of all the different terms of resilience as it relates to urban resilience. And it's almost like an infrastructure map. And it shows all these different categories and all these different groups. So you have resilience defined based on the built environment. You have resilience defined based on the ecological environment, based on the political science, based on social justice and these other things. And they all feed into the center of resilience, but there's no one at the center. They're all actors at the periphery working in their specific fields. I would say in the surveillance systems that we were working with when I was an epidemiologist, access to data was a premium. And the relationships were everything in doing that. And, relationships across agencies and things like that to be able to better access and integrate that. So I think certainly in theory, it makes for a more robust methodology in a resource-constrained world to best utilize those more specific tests in a more effective way. But the reality is that we're in a very compartmented world, and if those social bonds across sectors are not reinforced, and most of our bureaucracy and even within universities, the way we do research favors a siloed approach rather than a cross-sector approach. So unless we build those bridges across sectors, we're missing insights and we're missing opportunities that could come from that just because of the way we structure our society.
So Rolf, ASU under Michael Crow has been pretty good at, as far as I could tell, at crossing, sort of taking down some of the walls. And theoretically, here in the online space, maybe even more now than ever, because we're all constrained, it feels like we live in a potentially borderless world. So we could put a question at the middle.
Oh yeah,
and have it actually attacked with a more open approach. This came out on this Sustained webcast just a week ago, when, in the context of ecological economics, there were I did a conversation with Herman Daly, who pioneered that field, and then some emerging scholars who are at different universities. I convened them as to talk about how their field can expand. And one of the insights that came out was, hey, look at us right now. You're all at different universities. You're pursuing the same question. They actually had different backgrounds. One was from agriculture. One was pure economics. And they found each other. So is there an opportunity here, when there is a crisis like this, to sort of to force some of the, not force, but to facilitate having the right brains in the room at the same, and coming out?
Yeah, I could more. So the opportunity existed all along. If we continue to be compartmentalized, we will not make progress, right? If you look at all the major breakthroughs that we had, they always required multiple disciplines, and you took tools from different areas, bring them together, and you come up with something amazing. So the less frustration that we feel when we work at the interface, of a place, neither it's not medicine, it's not public health, engineering, and we are in no man's land with this wastewater-based epidemiology because it draws on all these three sectors. And nobody wants to talk with us because nobody feels truly competent, right? Ask a doctor to talk about the sewer system. Yeah, no, thank you. Public health official, I'm interested in cases. I'm not interested in, the general metrics. So it's driving me up and down the walls. So last year I decided to write up a little kind of, a book to just explain that we have to break down these borders. We are not separate environment. You can't violate the environment and maintain good health, right? So I wrote this little book, released yesterday for Earth Day Environment, published by Bloomsbury. It's the same. I'm just the net outfit, but what's frustrating is that we just struggle to get anything into peer review. Our community, puts out grant proposals that have a return on investment that is really amazing, like 2-3 orders of magnitude, and it's not taking hold. And I'm pitching to philanthropists, and they look at me as like, yeah, nobody's validating. It's just nobody's an expert in it. You actually are willing to ignore those borders, and I couldn't be more that ASU has done a fantastic job in, I think maybe that allowed me to be unique in the United States, have the access to social scientists. We work with bioethicists and people in law to understand what are the repercussions and implications of doing this type of measurements. What is morally and ethically okay, and where do you cross a line and it becomes a non-anonymous activity anymore, where you have to protect the privacy of people. So very, very complex environment. I wish we would just get rid. Just look at the National Institute of Health. We got all these institutes. We are separating them in diseases. You think these are all the diseases we have? And the environment has so many, over 50% of our diseases are impacted by the environment. Any investment we make there in improving environment quality directly translates in less sick people. And it's a huge cost savings, but we're just making these decisions. They are not very hard. And right now it's so spend $1 just on screening and then send your resources where they're needed.
You reminded me, there is an established, I think it's NHANES, NHANES. It's a national blood sample survey that's anonymous, so that you get these overall trends in like the presence or absence of PCBs, at parts per trillion. So there is an established norm, at least for at that scale, to preserve the anonymity, but to get the insights about trends and things.
That's right. We have actually analyzed. So that's the NHANES study that runs for over a couple of decades now, and it's a very large number of people, thousands of people that contribute, and have looked at what we call the body burden of the storage of toxic chemicals that we produce and that are not compatible with natural breakdown processes, and so they have no place to go. A lot of them are hydrophobic; they don't like to swim in water. So when they get a chance, they partition into fat. Now, we have a fair amount of fat tissue, so these chemicals accumulate in our body and create what we call a toxic body burden. And we discovered back in 2014 that we actually can use sewage sludge as a surrogate matrix to detect what types of chemicals are accumulating in the human body and what the concentrations are. And so by just measuring all those leftover chemicals that have no place to go in sewage sludge, and then comparing them in a XY scatter plot to what the NHANES study has on a lipid basis of contaminants in people. And so that gave us a straight line. And now we can go in when somebody puts out a new chemical that doesn't degrade. We can go to that curve and find the concentration in sewage and go down to the concentration in people and say, yeah, if you don't do anything about it, the amount of mass that you're going to see in the future accumulating in people. So it's very powerful, very inexpensive, and as we have heard before, that these studies don't require IRBs, so internal review boards and approvals, and so they are just orders of magnitude cheaper, as described.
There was a question that came in from Mike Miller. It says, for you, Rolf, it says, I live in Georgia. What kind of cost and time frame is required to get this system in place locally? I don't know if you want to think at the state level or Atlanta.
So it's not hard to, logistically, what you need to do is to just go to your wastewater treatment plant. It's always on. It always works. The people don't get credit. They always perform, right? And so they have to collect what we call composite samples. So they have a drum there that looks like a keg of beer. And there's a pump inside, and it draws sewage all day long, puts and fills it in a glass cylinder, and that's what we call a compliance sample. It represents really the chemistry of that day. And so if you connect to your public works director and get permission, you get a sample of that. And now your options are, you can send it to our laboratory, we analyze it for you, or you can find your local university if they are open and if they have the reagents and the assays, and perform this work. Now, with respect to performing the assay, it's not black magic, but we're still learning, right, of how to process a sample, how much we need, and what the best process is in order to preserve and then ultimately get the signal from the samples. But there is no doubt anymore. When we started this work, people said, well, it's impossible. It's an RNA virus, envelope that's going to fall apart when you just look at it. And sewage will never survive. We use so many detergents now that it will probably be wiped out immediately when it hits the sewage. And that's not the case. So we can detect the virus. The signal can be a little finicky, and we've seen that in the few studies that come out of Australia, out of the Netherlands and the US, is that you have detections on and off. And so it will require a little bit of finessing that. And I think there's a lot of labs that are still open now working on this. And so your options are, send the sample to us, to the Human Health Observatory, or send it, find a collaborator. And we can't wait to train more people. So we have to train the trainer here. We have to bring this technology around the world and deploy it. And particularly in the resource poor regions, like you think of Africa, a lot of places have seen no screening whatsoever. They will never get clinical samples for every individual. So that's where we can have the biggest impact. And we can measure not only wastewater treatment plants, but also latrines, and the systems where the sewage is collected.
Yeah, in fact, having spent a little bit of time in a couple of giant slums in Nairobi, they are watersheds, essentially. You see the rivulets and the waste all gets accumulated, even in places that have no actual sewage system. So that could be, I could see that being applicable there. So Jeff, I thought it'd be worth broadening out a little bit more to, let's focus on this question of the hammer to the dance, and Angela too, as we discussed here a week ago. What's given the challenges of having that detectability at the scale of a city or a neighborhood or a nation, where you want to know which states are most likely to have this resurge, and where you have to start to isolate and get to the human. Is there a system that can emerge that uses the wide scale testing and then deploys the serological or other testing and has the necessary capacity in time to be meaningful from now through the autumn? Maybe each of you could look at that from your expertise.
Yeah, I mean, I would say the first barrier is much more political than practical. Right, we have a very sort of homegrown kind of federalist structure with a lot of individual-based, these wastewater municipal treatment plants. Is it managed by the state? Is it quasi-public? Is it private?
Yeah, good point.
Is it, all of these different aspects.
Who owns them?
But at the same time, then you also have, what is the relationship? So if local health doing the surveillance, or state, and then is it a local municipality or not? So all of these are very, very real things in terms of how we organize ourselves that create speed bumps and the ability to coordinate together. And then the lack of really cohesive national leadership on this is certainly not going to help factors. That being said, and a more direct answer to your question, and to pull this into theory where it's a little cleaner, so to speak, is that, so each method of testing provides a different lens through which to understand what's going on, right? Diagnostic testing, the most of the testing that's being done now at the individual level will tell you, do they have detectable levels of the virus that they could be shedding? Are they sick? Whether or not they have symptoms. The serology testing, looking at the immune response, looking at were they sick previously? What's the immune response? A lot of sort of challenges with those testing, but ultimately gives us a different kind of population data. This is a very high level, right? Very broad strokes. But there are scenarios, particularly as we look to flatten the curve and we start to reduce transmission. And if we see that transmission get to very, very low levels, this could be very, very useful to do surveillance of wastewater treatment. And then in areas where you see it spike, then implement more specific testing in terms of, when I say specific there, I mean more individualized testing or more community-based testing to sort of have an early warning system of where there could be hotspots and things like that. A lot of unanswered questions in terms of how much are people shedding, when they're shedding it, how much is coming out through waste, but all of that to say that a good public health surveillance system, there is no single method. There are multiple methods, and each one provides different signals for different reasons. And understanding that that portfolio of signals gives you a richer understanding of the response and the measures that are needed, and the effectiveness of those measures.
So, Angela, what's your thinking? And I actually wouldn't mind you poking back to what you were saying about polio before, because it sounded like there was an established pattern there.
Yeah, so I completely agree with the scenario Jeff just laid out. I think that this could be really, really useful, especially since right now we know that our testing capacity is still not really where it needs to be. It's reliant on these limited resources that are in short supply. So if we could use a really high level method like this as an early warning system, you could redistribute those resources to the communities where they're going to be needed the most. So if you say community A has a spike in coronavirus in their wastewater, you could redirect tests from another community that isn't experiencing that same spike, right, so that we could actually identify those patients specifically that are infected, that are capable of transmitting, and do, again, these really time-proven epidemiologic approaches that work to break transmission chains. In terms of polio, so there's a couple things. One of the reasons that polio is monitored in wastewater is not just because they want to find out where there's polio, because largely we know where there is polio, since it's relatively uncommon in countries, and it's really doesn't happen anymore in countries where polio has been eradicated through mass vaccination. But you can actually get poliovirus from sewage. Poliovirus has to go through the stomach, and it's a non-enveloped virus. So even though it's an RNA virus, polio can last for quite a long time in a variety of different really unpleasant environmental conditions, including sewage. It's incredibly pH stable. It's fairly temperature stable. I mean, you can leave polio out on your bench, which I know this because this happened when I was in graduate school. I was in a polio lab. You can leave it out on your bench and there are not significant reductions in titer the next day. It still makes big, beautiful plaques the way polio does. Coronaviruses are definitely more unstable. They are enveloped RNA viruses. They have a much larger genome also, which makes their genome itself less stable. So the issue with coronaviruses, as Rolf pointed out, is not, we don't need the coronavirus to be intact. We just need it to be detectable. And I would suspect that some of the fluctuations they've observed in terms of detecting coronavirus, at least by PCR, is because it is inherently unstable. So you're only going to be able to detect pieces of it if they're around. But the good news is it sounds like you guys are pretty successful at detecting it, which means that we don't really care if the virus can be cultured out of the sewage. And unlike polio, again, the sewage itself doesn't prevent at least an environmental hazard for coronavirus transmission. It's just an indicator, really, that we can sample from and see if there's a likelihood of increased coronavirus cases, based on the fact that we know at least some coronavirus patients are excreting virus in the stool. So I think that, as that type of system, as a piece to a larger coordinated system that, again, requires a lot of coordination and relationships between agencies and people with various expertise, which I think is a real problem in terms of implementing this effectively. But let's just say that it could be implemented effectively and perfectly. I think that this would be a really important tool for us to have to monitor coronavirus in different communities, especially ones that may be experiencing a shortage of resources that are needed for individual testing. So I think going forward, this is really something that we should talk about more as part of our long-term strategy, because we are not going to have a vaccine, I think, for at least a year. I'll be very surprised if we have a vaccine before that. Pleasantly surprised, of course, but surprised. It could be even longer than that. We have 50 some vaccine candidates that are being tested right now. We don't know that any of them are going to work. So we need to have a long-term strategy for being able to monitor community transmission in real time. And it seems like a very cheap, easily implemented, at least in terms of implementing the actual work, easily implemented thing that all communities could potentially do. And again, the problem, as Jeff outlined, is really trying to coordinate between the federal response, the local water authorities, is it public, is it private, et cetera. So if we can overcome those challenges, I think this would be something that would be really great to have in our sort of epidemiological toolbox as we continue to try to respond in a dynamic way.
So, Rolf, I want to get your insight on this in a minute too. But the one thing that comes to mind is a lot of local water authorities rely on federal funding, I assume, to expand systems. Certainly, historically, that's how we built sewage systems. They're federal bonds, or not all federal, but many. So if there might be leverage going forward to see if there's a way to coordinate. Of course, that requires a government that's interested in coordination. We'll see how that works in certain parts of the world. And here too, like I think back to Gates Foundation in the 90s, the work they funded on the global burden of disease, which was to find patterns within big masses of data on the impact of public pollution on stroke or the like. It's all in the data. I would think this is the kind of thing that the Gates Foundation, I'm brainstorming here. I could actually try to ping some people there and say, hey, folks, is there a grand challenge here for either the philanthropy community to at least test having this become a normalized capacity? I don't know who else would be on that list, but it feels like ripe terrain.
Yeah, I think you're right on. I think it's mind-boggling why we don't pursue it. And so we have competed for the MacArthur Foundation multiple times. There's 2 videos out there, 90 seconds. You can watch them. We recorded in 2016.
Is it the 100?
Yeah, 100 million and change. And so we recorded it in 2016 and then, get an award. We posted in 2019 and all of a sudden it's relevant, but we still have not seen that the people jump on this. What other technology could be more important than finding out very quickly who is affected and who isn't? But I think I love that you brought us together. So kudos to you, Andy. And I love the cross interdisciplinary discussion. But let's assume that we sit like we do in the city of Tempe. We meet every month in the mayor's office, right, with everyone and discuss the fire chief, and everyone is there, emergency responders. Let's assume that the 3 of us here from the expert team would have to come up with a solution. And the facts are that the wastewater testing costs about 1/100th of a cent. Your clinical test costs about $100 per person, and maybe the serological, let's call it $100 too. And let's say we have a limited amount of money. Between the 3 of us, how would we structure to use our resources to, protect our community? What would we do? That goes to Jeff.
Well, before you respond, I'll ask each of you to name one person, one sector that could be in this conversation, that could make this more impactful.
Well, for me, it's easy because I can just say that we need the wastewater treatment industry, right? So right now, they operate very independently, or they are organized under large consulting firms that run the wastewater treatment plants. There's a lot of liability, if you can imagine. I mean, now we have even detected the virus in effluent. That makes it, challenging to communicate. But these folks have to be at the table because they can provide access, and they are key in this public health protection.
Jeff, what do you think?
Yeah, and I'll kind of try and answer both questions at once. I think, like I said, if you get $100 million, which I hope you do, if you get, I hope I get it more, but just you're a close second. Yeah, but sorry. But yeah, what do you do? And I think that this is one of the challenges, both one of the great things about groups like the Gates Foundation. There's a new group, CEPI, the Coalition for Epidemic. That are actually making,
yes. And I think it's initiative. Yes, they're making really great strides in terms of taking private sector innovations, helping to bridge those gaps between the public and private sector, but then ultimately
the world of surveillance, of epidemiological surveillance, is ultimately under the purview of government. And so it's really a political science issue more than a biological science issue. And so I would say that in terms of that, what are the incentives? So who do we need at the table? I mean, it really starts with the elected leadership, who at a lot of times are the least equipped from a professional expertise perspective, although you do get some folks in the field in elected positions to actually embrace this and address this. But bureaucratically and politically, they're in the position to draw together all of these different elements of society towards integrating this into a broader solution. And that's the thing too. A lot of what we're doing with COVID-19 right now, a lot of the tools that we're left with are very, very old tools, like centuries old in terms of identifying cases, isolating cases. Now we have new technologies, new ways of monitoring this. So the deployment of them in a way that takes advantage of these new technologies and takes advantage of all of the innovations we have at our fingertips. The barrier often, and as we're talking here today, is often not on the science side, is not on the technology side, it's on the organizational side, it's on the political side in terms of doing that. And so, again, I also agree with my colleagues, bringing folks from different sectors together in these conversations is very important for that. And I also don't mean to throw shade at siloization. I mean, you need deep research. You need people who are highly specialized and focused on what they do. We need them to do that, so I don't have to get too smart on any one thing. But you also need those bridges between them and to be able to bring folks together. One of the things I've always appreciated about the Earth Institute is trying to create an academic model that respects the siloization of traditional bench science while also creating a forum for that cross-sector preparedness. But I do feel very, very strongly that I think if you get $100 million, Rolf, to bringing these various partners together, but as part of the outputs is to also bring together the lessons organizationally. What are those incentives? What was it that got those elected officials involved? What is it in the day-to-day transactions of where people choose to be a part of one project but not to be part of another? I think those will be some of the most valuable lessons, in addition to the incredible scientific work that you're doing as well too, to really create the opportunities to bring that to scale.
Yeah. There was this video of the Dutch group. Are you Dutch, Rolf?
No, I'm German.
You're German, okay. Were you familiar with this other effort that
absolutely, yeah. So they were the first to report, and then two other studies. Then an American study in Massachusetts was published, and then the Australian group that actually is peer-reviewed. The Australian study, the other ones might still be in peer review.
So I guess what would be a next step if we did another iteration of this conversation in 2 weeks? What would be the way to zoom in further? It sounds like the political, maybe there's a case study or a city, if there's some place or some country where there's already some expression of interest. I would be more than happy to do another iteration of this that just digs a little bit closer to the concrete next steps. What would those, like any brainstorm on what that might be?
So I'd be really curious. Certainly in the Netherlands, there are a number of really world-class virologists, particularly at Erasmus Medical University or Medical Center, who are working on the virology aspect of it. So a lot of the really good serological tests as well as PCR tests have come out of those groups at Erasmus, primarily led by Bart Hagmans and Marion Koopmans. I would be really interested to hear how they're coordinating with the Dutch scientists who are leading these efforts to track coronavirus and wastewater, as well as how they're all working with the epidemiological folks who are trying to monitor this at population level. So it would be really interesting to me to hear kind of some of these stakeholders come together and talk about how they would practically implement this type of surveillance within the parameters of the sort of public health program they've already got going on, if that's possible.
And Jeff and Angela, maybe think about New York City, which presumably will be determined to try to, the New York region would be trying hard to determine how best to limit flare-ups going forward. Is
So-
there an architecture for that decision and that capacity too?
I have a feeling that Jeff is going to be better at answering this question in terms of what actually goes on in New York City in terms of coordinating this. But my question actually before that is for Rolf. And are you guys looking at New York City wastewater, or is this going on in New York City right now?
Don't jinx it. We've been trying to get access to New York City for a long, long time, and we are in discussions again to help them out. It is mind-boggling why all the resistance that we encounter. But we have hundreds of cities that work with us, and I think what to answer Andy's question, what we need to do is we need to have a plan and bring the people who have had success together. So recruit some of them who can speak to the detectability of the virus, what we can and cannot measure, right? Then look to a city that has successfully implemented wastewater-based epidemiology, like Tempe, Arizona. Bring them to the table and tell them what works and what doesn't work and why it's valuable. And then, this is a Manhattan project. You need to put an engineer in the front who understands what the budget is, what each tool can do, and then you execute a plan. So everyone can speak up, everyone makes their pitch, and then you see where you invest your money. But it's pretty obvious that we need to identify where the need is. And so we actually have started a nonprofit, One Water, One Health, just to give a chance to those communities who will never see any significant level of testing. Right? There's vast stretch of our country, including Native American reservations. There's no healthcare system, no insurance whatsoever. These people are really left behind, and they will be for a long time. So if you are a member of that community and listening, then please send us your sample. We analyze it for free from our nonprofit. But this is a Manhattan project. Put an engineer in place, have these, and it doesn't matter where you're coming from. If you can make a contribution, you're invited and welcome at the table. And take the people who have been most successful. Right now, the grant money is first among all these groups that say that I can do it too. But why don't you go to the experts who've done this for decades and have learned all the hard lessons, right? I mean, I don't see the urgency in the funding. Even if I send a proposal in right now, it'll tell me it takes 60 days. It's expedited review. Say, how many people do you have to sacrifice for this? We have all the credentials in place, and there's other experts that do other things. I just don't understand it.
And especially because it applies at both. Again, we've said this before already. At both sides of the problem: early identification, early forecasting, and enabling the dance, the response, this active response. So this feels like, I think we've hit some good points here. Maybe this is a good time to draw to a close. We have just a couple minutes left anyway. I will pursue that One Water, One Health. I didn't know that the communities could send samples right now. That's pretty interesting. And at Columbia, at the Earth Institute, at the Lamont Doherty lab, they do some of that too, but that's very different, not this kind of issue. So this was a very valuable step one in another direction here for our webcast. Clearly some iterations to work out going forward. I'd love to stay in touch with you, Rolf, and good luck with the book.
Thanks.
Jeff and Angela, I think you'll be on here periodically, hopefully, to help drive these conversations forward. This is aimed at several audiences at once. We're talking to the general public. This goes worldwide. It goes onto LinkedIn, Facebook, Twitter, YouTube. And I'm hoping to circulate it as much as possible within the community of funders and agencies that might be able to look at this 1 hour and have a sense of some things that could be thought of in a new way. So it's been great to have you on board. Any or just a quick last round from Angela, Jeff, and Rolf, if you have one last thing to say, that'd be great. Angie, what's next for you, like next week?
Oh, what's next for me? Well, last week I did get a small grant to look at host responses to SARS coronavirus 2 infection in a rhesus macaque model. So I'm getting those samples in and we're getting started on that work. So that's exciting. And then who knows what other stuff is going to happen next week. Just in general in the world, every day is a new day and a new adventure in COVID time. So I have no idea what I'm probably going to be thinking about, talking about in terms of the news next week. But I definitely will be getting started at least on my own coronavirus research program. So that's exciting for me.
And Jeff, what are you thinking about in the most urgent timeline?
Well, lunch first and foremost, but after that, we've got, you think I'm joking, but priorities. So a lot of our projects in terms of working with child serving institutions and communities have taken on a whole new relevance in terms of their connections within the community and sharing of resources. And so we're just have some wonderful partners who are doing great work that we're fortunate to be a part of there. Some training programs we're doing on community economic recovery preceded coronavirus, but obviously are very relevant now. And then, of course, the work of our director, Erwin Redlener, doing a lot of framing of this through roles with the media and advisory roles, as well as working with some various donors on meeting some of the immediate needs. But then for me personally, it's always been, I really appreciate this conversation because to me, it's always about, there's so much information coming at us and a fire hose of information, but how much of it is really actionable and how can we down select into what we can do now while we wait for the picture to get clearer with the other research that's going on. And I think this has been a great conversation, and we're involved with a few other private organizations in terms of also helping to come up with better tools for framing uncertainty and working amidst uncertainty rather than being paralyzed by it or trying to pretend that we're in a deterministic world when it's really much more chaotic. Chaotic being the scientific version, not the existential version.
Right. You have to live with the complexity and deep uncertainty and make decisions. One of my favorite go-to places in this arena is the Society for Decision Making Under Deep Uncertainty, DMDU. It's deepuncertainty.org. And it's a thing. We need to get used to this thing in a hurry. And Rolf, just the last quick word would be great from down in
well, first of all, Andy, thanks for getting us together. I think this was a very productive discussion. I certainly learned a lot, and I'm enthusiastic about the fact that you see that we have to bring people from different areas together. It looks as if our country right now doesn't have enough resources and we just can't move, but that's not true. So if you look alone to ASU and the Biodesign Institute, we have over 600 volunteers that are standing at the sidelines to be ready to analyze clinical samples. So if there's a place in the US that needs clinical sampling right now and has good reason to, for additional samples, then please contact Joshua LeBaer, who's our institute director. There are community. Josh LeBaer, yeah. If you have communities that are seeing no support traction, have no healthcare, what to speak, are socioeconomically disadvantaged, go to onewater.onehealth.org. This is a non-profit. We can provide free testing for your community at the wastewater level. And if we have see a high level of infections, we could follow up with clinical tests delivered through our institute. It's amazing how many resources really there are, but we're not sharing it, and we can do a better job. So I'm enthusiastic about this conversation. Would love to keep it going, and again, contact us for help. We'll be happy to.
That's fantastic. Well, thank you all for being part of Sustain What. I'd like to end by
my pleasure,
acknowledging the people around us who are directly on the front lines. And again, as I've said here before, this is unlike any other war or there's something distinct about pandemics in that it's pervasive. The front line is everywhere. It's from your supermarket stock taker to the janitor, as well as the pulmonologist at the local hospital. We have to honor their service and their sacrifice, unfortunately, increasingly sacrifice as well. And one key thing is to do what you can with what you have. And what I have is connectivity. So my job is to connect people and foster some outcome-based discussions going forward. And thankfully, the Earth Institute at Columbia University has given me the position to do that. So the more of this, the better. I call it communication and sustainability ? How do you move forward? There's no shortage of information. Quite often, it's a shortage of connections that makes that is the bridge that has to be crossed. So thank you all for being here. Onward and upward.
Thank you, Andy. Take care, everybody.
Take care, everyone.
Thank you.
Nice to meet you.